Okay, well, welcome everyone, and thank you for joining us today. My name is Bill Manning, and I'm Executive Director of ASPI. I've been on active surveillance since 2009, and I'm actually still a member of my local support group that got me started on this journey. So, our purpose here is to educate individuals about options regarding AS, which is not a treatment, but a management plan. I would like to remind everyone that we are not anti-treatment, but anti-unnecessary treatment. So a couple of quick housekeeping measures. We're going to hold off all questions until after the speaker. You can submit questions in the chat box, which we will try to address. And at that time, you can also click the raise hand button from the bottom of the Zoom window toolbar. And if there's time, we'll try to call on you. Please keep yourself muted during the meeting. The speaker presenting here today is generously donating their time, so we want to be very respectful of that. We also are not here to dispense with any medical advice. Nothing said during these meetings by our speaker, ASPI, or the audience should take the place of consultations with your medical professionals. Also, you do not need to feverishly take notes during the talk, as this meeting is being recorded and will be available on our website in approximately 1 week, and you'll get an email notifying you when it's ready. Also, if you subscribe to our YouTube channel, you will automatically be notified whenever a new video is posted. So, without further ado, we'll have a few quick words from Mark Lichty, our chairman. We'll then turn the meeting over to Howard Walensky, the organizer of this meeting, to introduce our guest. So relax, enjoy the meeting, and I hope you leave here a little bit smarter. Take it away, Mark.
Thanks, Bill, and thank you all so much for coming. We try to create a sanctuary on Saturday morning where you can talk openly, and hopefully through this education process, any anxiety that you may have will be diminished in the next hour and a half that we're together. I'm excited to announce that ASPI has completed the first review of clinical trials on just active surveillance that anybody has ever done. And I think all of those clinical trials are still open in case any of you want to sign up for them. Just go to our website. And we have more and more people that need help, and we were not able to accommodate all of you. And so in order to do that, we had the opportunity to hire a woman out of Prostate Cancer Canada. Her name is Rochelle, and she's excellent. And hopefully she will be able to provide even a higher level of service to you folks. I had mentioned at the outset here, we were kind of talking at the beginning that I recently received a PIRAD-4 diagnosis with the MRI. Now, what we found is that MRIs are sometimes blunter instruments than we think they are, and so I'm going to get a second opinion. In fact, I just called my provider this morning, and they said no problem with paying for the second opinion on your MRI. So we've had a number of people that have had second opinions on their MRIs or other second opinions, by whatever, and they've been reduced. So I'm gonna have that second opinion done, and hopefully I'll have to avoid even a biopsy. I haven't had a biopsy in 20 years. 20 years ago, when I was first diagnosed, I got concerned about sepsis, so I just quit having biopsies. Um, so I'll let you know where that all goes. I did want to mention too that pretty soon we're going to be announcing the Shodak Awards. Now, In that, we recognized somebody, a doctor that has had courage in bucking the headwinds, fighting against active surveillance. And interesting how in the past 10 years, the headwinds have almost become behind us now, and we have a lot of support for active surveillance. But there are certain very courageous doctors, and Jerry Shodak, who the award is named after, was one of those first doctors. And we also have a patient award, and so we'll be announcing them probably within the next week. Um, I I thank Dr. Ginsburg. Thank you, Dr. Ginsburg, for being here today. You know, you have lots of other things that you could be doing, and these doctors donate their time, and we don't have the money to pay them, and they don't ask to be paid. They just care about you, and that's why they show up, and we're very appreciative of that. So I want to introduce Howard Walensky, and Howard's he's the author of the Active Surveillor newsletter. If you have not yet signed up for the Active Surveillor newsletter, do sign up for that. I will say in this forum here that I don't know of anybody on the planet that has made a bigger difference in terms of active surveillance than Howard has. And so thank you, Howard, for bringing us Dr. Ginsburg, and the floor is yours.
Okay, Dr. Ginsburg will start in just a few minutes, but I want to tell a short story. Urologists were slapping high fives when the news was released in 2022 at the American Urological Association's annual meeting that for the first time, the majority, 60% of patients with low-risk prostate cancer opted for active surveillance. Active surveillance had finally broken out of academic practice and was becoming part of mainstream urology. What was next? Well, the AUA committee announced a seemingly reasonable goal of 80% on active surveillance sometime in the vague future. Then someone at the meeting spoke up, a voice from Michigan. Michigan, it turns out, is a hotbed for urological reform, especially for active surveillance. Speaker was our speaker today, Kevin Ginsburg, a urologic oncologist from Wayne State University in Detroit and co-director of the music program. He stepped up to the mic and said 80% simply was not good enough as a goal, and he called for a more aggressive migration to active surveillance. Kevin will be presenting today, but he'll be talking about Gleason 3+4 and whether it's the future of active surveillance. So should mention one last thing. Kevin and his colleagues at the music group in Michigan won a special award from ASPI in 2023. So Kevin, you're up.
All right. Well, thank you very much for the introduction. I'm going to share my slides potentially. And could I ask someone to confirm that we're seeing full screen? It looks great.
Full screen and looks great.
Yeah,
Awesome.
that's great.
I got this little laser pointer here too now. All right. Well, thank you very much for the invitation as well as the introduction. As Howard said, my name is Kevin Ginsburg. I'm a urologic oncologist in Detroit, Michigan. I work, my clinical practice is at the Karmanos Cancer Institute. And additionally, I'm the co-director of something called MUSIC, which is the Michigan Urological Surgery Improvement Collaborative. I'm the co-director of the prostate program. And it's hard for me to talk about active surveillance without dedicating some time to music also, just so people are aware of this great program and the resources that it has. Let's see. By way of disclosures, I do receive salary support from Blue Cross Blue Shield of Michigan through their Value Partnership Foundation for my work at MUSIC. And also I served on an advisory board for Johnson & Johnson about defining quality metrics in prostate cancer. Pretty non-controversial disclosures. Okay. All right, here we go. The down arrow apparently will be the advancing key today. So we're going to talk just a little bit about prostate cancer. I'm sure everyone here has a pretty strong foundation, but just make sure we're all on the same page to set up. Then talking about where we are in with active surveillance for grade group 1 and low risk prostate cancers. I'm going to hijack and then talk a little bit about music and go in a different direction, then talk about what I think the future of active surveillance is going to be. And that's expanding our enrollment criteria to some men that have favorable intermediate risk prostate cancer with grade group 2 disease. So a bit about prostate cancer. So let's get cooking here. So just so everyone's aware, prostate is a male organ, sits beneath the bladder. The urine tube runs through the middle of it like a hole through a donut. All right. And prostate cancer is very common in the United States. 1 in 6 American men will develop prostate cancer in their lifetime. And 1 in 6 men with prostate cancer will unfortunately pass from prostate cancer. So, prostate cancer has very significant burden of disease to it. In terms of who's getting prostate cancer, it's mostly the age around men in their 50s, 60s, and 70s. As you start to see here, the amount of men diagnosed in their late 70s and 80s is starting to decline as less and less. It's not that the disease doesn't exist there, but as we've been saying earlier, as I think Bill said, we're against unnecessary treatment in ASPI, not against treatment, but as urologists, we're trying to be against unnecessary diagnosis. So we're looking less in men that are less likely to benefit from the identification of prostate cancer as men start to age. Are there any symptoms of prostate cancer? Well, the answer to that is almost uniformly no. Unless the cancer is very advanced or someone has very bad cancer, then they can start to develop symptoms either from the spread of a cancer or from just locally the cancer in the pelvis causing problems. But for the most part, it's asymptomatic, even at some advanced stages. And importantly, we get this one a lot. Difficulty urinating, weak stream, frequency, urgency, waking up at night. These are all symptoms that are caused by the prostate, but not necessarily prostate cancer. This is usually just from growth of the prostate as men age. All right. So no talk about prostate cancer is complete without briefly talking about screening. This in itself is a whole Pandora's box of a talk, similar to how we said just talking about whether or not we should call grade group 1 prostate cancer anymore is its own talk. But in general, most prostate cancers are detected by PSA screening. With broad strokes, a PSA higher than 4 is often considered abnormal. But again, there's some nuance to that as well. As we were discussing earlier, there's additional tests, things like PHI, MRI, other blood and urine tests that can be used to kind of help circumvent a lot of the limitations of PSA in identifying not just prostate cancer, but clinically significant prostate cancer, cancer that we want to find. And then in 2025, still the only way to really diagnose prostate cancer is with a biopsy. There's other tools that can help suggest the presence of prostate cancer or even suggest the presence of a clinically significant prostate cancer. But the only way to truly tell is still a biopsy. The Gleason score is very important when talking about prostate cancer. This is an old system. We don't use it anymore. It wasn't very intuitive. It was composed of a score was composed of a primary pattern with the addition of a secondary pattern. So 2 numbers added together to equal a third number. It wasn't a great system, truth be told, because the lowest number is 6, and the highest number is 10. If you tell someone they have a 6, well, that's already higher than 5 and closer to 10 than it is to 0 or 1. So it wasn't really a good system. I think it generated a lot of confusion. But when we talk about grade group 2 and favorable intermediate risk prostate cancer, it's still important to understand the Gleason scoring system because we do talk about the percent of pattern 4 because that is an important component of this. But we've really moved away from this Gleason scoring system in general, and now we're talking about grade groups. It's a lot more intuitive of a scale. We go from 1 to 5, with 1 is lower risk and 5 is higher risk. And it's something that I think resonates a lot more with patients. We then take this biopsy grade group, we take the PSA, we take the clinical stage from either a rectal examination or from some imaging to then determine a risk grouping. And this is important, again, now when we're talking about active surveillance, because this is really, we're going to be talking about very low risk, and favorable intermediate risk prostate cancers. And it's important to understand how we got to those buckets. There's a couple different systems. There's minor nuance differences between them. They're all fairly similar. I tend to use the NCCNs here, which again, when we're talking about active surveillance, we tend to be talking about this group boxed off in here in red, which is men with low risk prostate cancer, very low risk, low risk prostate cancer, as well as favorable intermediate risk prostate cancer. The low risk and very low risk groups are pretty homogeneous groups. These are men with grade group 1 prostate cancers, low PSAs, and either very low volume disease or, still again, just more than that very low volume criteria. Grade group, favorable intermediate risk, though, is a little bit more heterogeneous. There's kind of two main ways that you can get there, and that is with grade group 1 prostate cancer and a PSA between 10 and 20, or grade group 2 prostate cancer and a PSA less than 10. So a little bit different, some different groups of patients in that favorable intermediate risk group. So this is probably preaching to the choir. I'm sure a lot of you know a lot of why we do active surveillance and why we care about active surveillance and why we just don't say, well, there's cancer, just take it out. Well, that's because the prostate's at a very sensitive location. It's not like it's just on elbow skin where you got extra elbow skin there, so just take it off and you're never going to notice it. There's very serious quality of life implications that can happen with the treatment of prostate cancer. That's impairment in urinary function. That could be in the form of urinary incontinence, overactivity, blood in the urine. Sexual function, that can be with erectile dysfunction, that can be ejaculatory dysfunction, bowel dysfunction, again, diarrhea, constipation, pain with stooling, blood in the stool, and hormonal function. Sometimes with the treatment of prostate cancer, short-term hormone androgen deprivation therapy can be given with that, and that has very serious quality of life implications too, with some fatigue, some just kind of not having enough wind in your sails, loss of libido, some smooth muscle loss, weight gain, all things that can happen, not necessarily will happen, but can happen. Thankfully, a lot of these can be minor, they can be managed, and they can be self-limiting, but others, unfortunately, are severe and lifelong and really unfortunate side effects that can happen. And so, as a consequence, we want to be thoughtful about who should be treated. Additionally, many prostate cancers in the short, intermediate, or even long term. Sorry, my boss is text messaging me. He's on call. Yes, no problem. Sorry. But in the short, intermediate, and long term are often not lethal. And as a consequence of that, we don't want to treat people if we're asking them to incur the risks of treatment without much in the way of benefits of that treatment. So this is from a study from actually Europe in the 1980s and 90s, where men either had prostate cancer surgery or they had watchful waiting. And that's very different from active surveillance. But the context, I think, is important in terms of framing the risk of some prostate cancers. And this is showing that as time goes on here, the amount of men here in this dark blue box that died of prostate cancer without any treatment, again, different from active surveillance, for which we're saying we're going to treat you if and when we get to that point. But this is saying never treatment. Only around 20-30% of men, even when you get 20-30 years out, died of prostate cancer. There's some men here in this next blue box that developed the spread of a prostate cancer but died of other causes. There are some men in this lightest blue box here that had some additional treatment, some hormone therapy for their prostate cancer, but still died of another cause. Then there are all these men up here that died of other causes, never needing hormone therapy or developing metastasis of their prostate cancer. And then lastly, a fraction of men still alive and well. Unfortunately, just when you're talking about 20 years in the future for someone who's already in their mid 60s or 70s, you just have more years behind you than you do in front of you. That's just kind of the fact of life. So again, not a lot of these cancers will be lethal. but some cancers will be dangerous. And that's really where active surveillance came in, because we want to find and treat the men that have cancers that they'll benefit from that treatment up front. We want to avoid the side effects of treatment in men that are not going to derive much in the way of a benefit from that prostate cancer. And we want to treat and cure the men that were in that bucket of men that didn't need upfront treatment if and when we get to that point when that disease renders itself. And that's where active surveillance really comes in here as this Goldilocks of having your cake and eating it too. Still treating and curing men that are going to benefit from it, avoiding the risks of treatment in the men that aren't going to, and then treating and curing them if and when we get to that point. How's surveillance performed? Things like office visits. We heavily use PSA, and then we use some other tests now. This is supposed to be an MRI machine, as well as prostate biopsy as well to assess the disease within the prostate. PSA testing, easiest to do. It's a blood draw, but it's also, unfortunately, just the least helpful of all. It's great when that PSA is staying rock stable and not moving. Well, then we have a lot of confidence that the cancer itself is probably not changing and growing as well as we're monitoring. But unfortunately, if the PSA is fluctuating and doing one of these, it can be less helpful, unfortunately. We have imaging. We've already talked about MRI some today, is really good at helping us determine what could be in the prostate. It's probably best in terms of telling us what's not in the prostate. We have a reasonable amount of confidence that with clean MRIs, when we layer in other tests too, like PSA density in there, we can have a lot of confidence that big bad disease is not present. Micro ultrasound is coming on the scene as a potential way of a point of care test. And then also someday in the future, maybe PSMA PET is going to be used here as well for monitoring while on active surveillance. Biopsies, unfortunately, still necessary in 2025, maybe not the way that it was done with Bell Carter at Hopkins in the early 2000s with a biopsy every year like clockwork. But unfortunately, we still are relying on biopsies ultimately to tell us the disease that's in the prostate and if that disease has changed. What does monitoring look like? Well, it can be different on active surveillance for different men. This is from a snippet from our roadmap for the management of favorable risk prostate cancer from Music. All right. This is an idea of a high intensity plan and a low intensity plan, where for more intense surveillance, we're doing PSAs in the every 6-month range. We're getting a tumor burden assessment, whether that be an MRI and a biopsy, much more frequently, maybe yearly or so. Lower intensity, again, these are just ideas for what this can look like. There's a lot of flexibility in here, but maybe more PSA every year or so, MRI and biopsy every 3-ish years. This is unfortunately already old. A lot has changed. This is from 2015, 16-ish. We know a lot more about active surveillance in the 10 years that we've since publishing this roadmap, and we're actually in the process this year of updating this and providing some kind of refreshed, updated guidance in this regard, just because the field has changed so much in the last 10 years. So again, historic active surveillance, again, limited to men with very low risk disease, low volume, low risk disease. You can only have a few areas, biopsy cores, spots of that group 1 disease. You had to have a low PSA. Biopsies were the mainstay of treatment, depending on the protocol, somewhere to 1 to 3 year range. And then if you had an increase in the volume of group 1 disease, if you had some group 2 disease, if the threshold for treatment was unfortunately rather strict. And that, I think, took a lot of men off of active surveillance that maybe in 2025, a little bit of group 2 on there, maybe we would say, hey, let's keep an eye on this still. So, but nonetheless, it was an important first step for active surveillance. And, this really did lay the foundation. And this is from Hopkins. This is again showing, I believe this is Jeff Tusoyan's paper. I'm sorry, I left the reference off here. But this is showing their 15-year outcomes, that the risk of death from prostate cancer, the spread of a prostate cancer with real aggressive surveillance was thankfully very low, like very few to no events in this cohort of over 1,000 men, almost 2,000 men. But we do start to see, again, some of these other causes of death starting to sneak in. Heart disease, strokes, I think other cancers, just because, again, when you're in your mid 60s and 70s, unfortunately, those things do start to catch up with you. This is from another very important active surveillance cohort. This is Klotz's data from University of Toronto, again showing that the risk of dying of prostate cancer when you start on this journey of active surveillance is thankfully very low. The folks that really know the differences between these two cohorts, Hopkins cohort, very strict, rigid criteria, Toronto, looser criteria, did put some men with some group 2 prostate cancers on active surveillance. The interval of testing was much less burdensome and much less intense. But even so, despite the fact that very different ways of doing surveillance, the outcomes of which are still excellent in terms of helping limit the amount of unnecessary treatment and then keeping people free of death from prostate cancer if needed. And then lastly, another very important foundational paper and evidence in active surveillance. This is from the PROTECT trial, where men in the United Kingdom in the late 90s, early 2000s agreed to participate, where they were randomized, meaning the flip of a coin into which treatment they got, whether that was surgery, radiation, or active monitoring. It's important to know that active monitoring is not necessarily what we would call active surveillance in 2025. Again, it's probably a little bit closer to watchful waiting than it is to truly the tests and monitoring that we have to use today to help monitor. But nonetheless, regardless of the group that these men were randomized to, patients did phenomenally well. The risk of prostate cancer death 15 years in the future was 2%, whether they started with surgery, started with radiation, or started with active monitoring. Again, suggesting that there's a long lead time. We can safely monitor a lot of men and still safely treat them if and when we ever get to that point. And this is from my own group. This is from Music, a paper that we published looking at men with low-risk prostate cancer that were treated upfront, meaning immediate surgery. They just decided, again, this is probably a lot of men earlier on, in closer to 2012, 2015. They were treated of their low-risk prostate cancer up front. And this is men in blue now that started on active surveillance and then were treated a number of years in the future, that their risk of needing additional treatments, have we taken a disease that's really easy to treat, where patients do well, and have we made it harder, that now we're increasing their burden of treatment in the future, that now they need to have radiation therapy or hormone therapy and additional treatments, and basically shows that their risk of needing additional treatments in the future is very similar between these two groups, very small, again, suggesting that we don't lose much in the way of trying active surveillance for men with low-risk prostate cancer, that if they go on to need treatment, they're going to still do, thankfully, very well. Nationally, as Howard said, what does this look like? The use of active surveillance here in orange has thankfully increased for men with low-risk prostate cancer. This is from SEER, national data in the United States for men with low-risk prostate cancer. We see a decline in things like prostatectomy and radiation amongst these men. This is the exact paper that Howard was referencing, saying that at the AUA in 2022, this is data from AQUA, the AUA's American Urological Association's quality improvement registry named AQUA, showing that over about 60% of men in 2021 with low-risk prostate cancer within this national registry were going on active surveillance. So again, suggesting we're moving in the right direction. But as Howard said, I was not satisfied. We could do better and we should do better, quite honestly. And this is our data from Music over the same time periods. We did put the other treatments on here, the other colors, but again, focusing on the green colors side by side, we actually in 2021 eclipsed 90% of men with low-risk prostate cancer going on active surveillance. And truthfully, I think that number should be higher. I think it should be 100%. This was already elucidated earlier that we know that men with low-risk prostate cancer does not spread and does not kill. And of course, there's the concern for missed other disease, higher risk disease that could be in there that was missed. But nonetheless, I think that there's room for improvement here too. I think that we can still do better. And I think this is a good point to now pivot. I brought Music up a handful of times and talk with you all a little bit about Music. Again, an organization that I think has been instrumental nationally in helping increase the use of active surveillance. So Music stands for the Michigan Urological Surgery Improvement Collaborative. It is a group of over 260 urologists throughout the state of Michigan from 46 different practices. It's around 95% of urologists in the state of Michigan participate. We have patient advocates that are really the backbone of this quality improvement work. It's a massive registry now of patients that we use to drive quality improvement. And of course, some publications and research in there as well to help move the field forward. And so this does not exist in isolation, this quality improvement collaborative. This is actually one of around 17 quality improvement collaboratives that are funded by Blue Cross Blue Shield of Michigan that really are a very generous and partner in this in funding these collaboratives in other areas of medicine as well, type 2 diabetes, radiation oncology, medical oncology, obstetrics. I assume this one has something to do with like COPD or lungs. It's a very diverse portfolio of quality improvement collaboratives. So Music was founded in 2011, 2012 by Jim Monty, who is a urologic oncologist at the University of Michigan, and David Miller, who is now, I believe, either the CEO of Michigan Medicine's hospital system. He's someone very important. But nonetheless, started in 2011 as a very prostate-focused group, and this is now what I am the co-director of. But we also have other organ systems within urology that we focus on as well, such as kidney stones, as well as kidney masses and kidney cancers. And we have a very lofty but aspirational goal of basically making Michigan the #1 place in the world for urologic care. What makes Music special? Well, again, we have our patient advocates, very, again, generous people who donate their time that care about improving the quality of care for patients with prostate cancer and other urologic diseases. It's a coalition of the willing. No one is being told that they have to be there. People want to be there because they see the value and they want to be part of this organization that improves the quality of care that we are delivering. We have a great atmosphere. We show this slide with all these words at our meetings to remind people that, again, this is really a group of people it's non-competitive. We're trying to help each other. It's cliche, but we really do believe a rising tide can lift all boats here. The registry is a very important part of what we do. It's far too easy to think that you're doing the right thing. Oh my goodness. People are over-treating low-risk prostate cancer. 40% of men are still getting treated. Well, that's not me. Do you know that? Prove it. What's your data? And so that's what the registry really does, is it really allows people to understand their practice patterns. Or if not, it's just far too easy to say, like, well, that's not my experience. Well, you know your data now. That's a very important part of this. And it's a little cliche, but if you can't measure it, you can't improve it. We are in control of our registry, which is very important. It's not claims-based, doesn't come from SEER or the National Cancer Database. This really it comes from us, and that's important because we can pick what very important details are going to be abstracted and included in this to drive quality improvement. Again, we are in control of our registry, so as a consequence, as the field changes, as MRI and targeted biopsy started to become a thing in the later part of the late teens, 20 teens, excuse me, well, we added that into the registry. Now we track those things so we could feed that back to urologists so they can understand. Another good example is some of the AI-based biomarkers are now working their way into clinical practice. We're including those in the registry so we can understand how is that influencing patient care and outcomes. And additionally, some of these registries like SEER, they lag several years behind. Our registry lags around 3 months behind. So it's pretty up to date in terms of driving QI and understanding what your practice patterns are like. Here's just some examples of kind of what this can look like. This is exceedingly old, and I need to update this slide because this ends in 2019. But nonetheless, just some ideas of what are we feeding back to practices? What does it look like? How do they get it so they can compare their practice or themselves against the rest of the collaborative across a whole variety of metrics that are important for improving the quality of care that's being delivered. We then take it a step further. It's not just about data and feeding it back to practices. That's helpful, but we then help provide tools to drive that QI and to change practice patterns. And we do that in several different ways. We have triannual meetings where we get together. Howard was at one of our meetings where we talk about the kind of most pressing areas in quality improvement that we're focusing on. We meet with the individual sites and review their data for them to, again, look for opportunities for quality improvement. We've generated tons and tons and tons of both physician, provider-facing resources, as well as patient-facing resources as well. Here's just, again, some examples of brochures that we have for patients as well that provide education. And these are all freely available on our website. I realize I probably should have put it down here. It's musicurology.com. If you Google it, it will come up. And there's, again, lots of great patient-facing and other doctor-facing resources as well that we have available for everyone to use and benefit from. So, how have we contributed in the realm of active surveillance? Well, one of the landmark studies, this is from 2015, showing the wide variation in the use of active surveillance amongst practices with men with low risk prostate cancer. When you look within the practices, at now each of these dots is a physician within a practice, even crazier variation. Some practices go from 0% to almost 100%. There was really no rhyme or reason. And we realized this is a huge area to improve for quality. The care you get should be dictated off of you and your preferences and your disease, not which door you walk through and then which doctor you're sitting in front of. And so we met as a collaborative, meetings upon meetings, understanding, who's appropriate for active surveillance, how to do active surveillance, all these different things. And we then put this into this roadmap for favorable risk prostate cancer. And as a consequence of these initiatives, it wasn't just the roadmap, multiple initiatives, data, again, feedback, audit and feedback to the practices. We see here that when music was first founded, the use of active surveillance was very similar to that of a nationally representative cohort in blue here. But once we really started to focus on active surveillance, realizing that this was a huge opportunity for quality improvement, we see that the use of active surveillance in music really took off and just eclipsed that of a national of the inertia that was already happening nationally in the United States. And we've grown some too. Now we're starting to grow outside of music. We have some practices, mostly on the East Coast for some reason, that are starting to participate in music as well. Again, we're trying to expand our impact and our brand of quality improvement from just the state of Michigan now to hopefully elsewhere in the nation as well. So again, music, I think these are some of the foundational pillars that have made us very successful. Again, we try to be non-competitive. The purpose of this is not to say that Wayne State University and Kevin Ginsburg is the worst and everyone else is the best. That's not the goal. It's really we want everyone to improve together. Again, very data driven. We want people to know their numbers and their practice patterns so they can, just be very realistic about them and use it to improve the care that they're delivering. Back to active surveillance now. So active surveillance in 2025 for men with low risk prostate cancer is exceedingly safe. There's excellent cancer outcomes if and when patients do need treatment. We don't miss the window to treat and cure people as long as we're being diligent. And then again, is really the standard of care and for men with very low risk and low risk prostate cancer with very exceedingly few exceptions. But as said earlier, are we excluding too many men from active surveillance with these historic definitions and criteria of only very low risk and low risk prostate cancer? And then the other side of that too is, are we treating men too soon? The criteria, the threshold for treatment historically was increase in volume of group 1. Well, you now have more of a disease we're trying not to call cancer. We've coalesced around this idea that treating someone with low risk disease up front is over treatment. So why is treating someone on the back end if they still have low risk disease suddenly okay? And what about men with low volume grade group 2 disease? This also is an opportunity that maybe we're treating these men too soon. So it's important to understand that when we're talking about grade group 2 disease and favorable intermediate risk disease, that this is a higher risk disease, but this is not high risk disease. The absolute risk spectrum, it's still actually pretty darn low. And again, when we're talking about favorable intermediate risk disease, we're talking about men with grade group 1 prostate cancer and a somewhat more elevated PSA in that 10 to 20 range, or we're talking about men with grade group 2 prostate cancer and a PSA of less than 10. And it's very important. We're bad with terms in urology as determined by the Gleason score, which again went from 6 to 10, which is silly, that we also have this term favorable risk. That's different. This is kind of a grab bag term now of low risk and favorable intermediate risk together. But again, when we're talking in the next several slides, we're talking about favorable intermediate risk disease. And again, it's important. We can't completely ignore the Gleason score, even though it's a terrible system, because again, when we're talking about grade group 2, we're talking about this pattern 4 in here, this 3 plus 4. And by definition, it has to be at least less than 50% of the cancer in the core, or else that would now be grade group 3 or 4 plus 3. But a lot of this criteria, when we're talking about active surveillance for low volume grade group 2 disease, we're focusing a lot about how much pattern 4 is there. So why does it even make sense? Why should we think about expanding active surveillance to men with grade group 2 favorable intermediate risk prostate cancers? Well, if you look here, a whole bunch of men, this is a multi-institutional cohort of patients that underwent a prostatectomy. They were treated for their prostate cancer. But if you look at the development of metastasis here or death from prostate cancer here, the men down here that have low risk prostate cancer and favorable intermediate risk prostate cancer sure look pretty darn close and look distinctly different than men with high risk prostate cancer and unfavorable intermediate risk prostate cancer. Again, whether that's in terms of metastasis or prostate cancer mortality. And again, these men here in blue is a group of men that we've coalesced around active surveillance being appropriate for them. And so the outcomes of this group in yellow look pretty darn close to this group that we've said really should be on active surveillance. When we look at one of our tools here, this is kind of a prostatectomy outcome prediction tool here. If we focus over here on seminal vesicle invasion and lymph node involvement, we take someone who, again, we universally would say this man slam dunk is appropriate for active surveillance. Again, very low risk here of seminal vesicle invasion or lymph node involvement. If we take someone who now has favorable intermediate risk disease, where there's controversy around should we do active surveillance or treatment? Well, we don't want to lose the war. Their outcomes look very darn close in terms of these bad things here of seminal vesicle invasion or lymph node involvement if we were to treat that patient up front. This is one of my favorite websites. It was developed by Vincent Nanapargarasam. I always have to look at his name in my mind when I pronounce it, at Cambridge in the UK. And this is a very helpful tool in framing what is the potential risk of active surveillance as opposed to upfront treatment. So if we plug into this calculator, some other variables that's not included here, including health, but nonetheless, we take basically a healthy 65-year-old person, 4 or 12 cores of grade group 1 prostate cancer, against slam dunk, active surveillance. What would happen to this patient if they went on active surveillance versus if they had upfront prostatectomy? Well, unfortunately, 12 men would die of other causes. Again, when you're 65, unfortunately, those things can catch up with you. But 85% of men here would still be alive and well if they did elect to start with additional conservative management. 3% of men would die of prostate cancer with active surveillance. And if we treated all 100 of these men, we can make 2% or 2 of them live longer. So when I explain this to patients, again, this idea being, if we were to treat you of your prostate cancer right now, instead of starting with active surveillance, there's a 2% chance that I help you live longer and then I've helped you by doing that. Now, when we have someone with 2 or 12 cores of grade group 2 prostate cancer, again, urologists, we're like, well, I don't know what to do with this guy. It's a gray zone here. It's sorry, I advanced one too many. The outcomes, the risk of delayed treatment in this group, from at least with this prediction tool, looks exactly the same. That again, we are uncertain if active surveillance as a group of urologists, as cancer specialists, we're uncertain if they're appropriate for active surveillance, but really their risk and the benefit they derive from treatment of their prostate cancer there's still a lot of men that are going to be able to stay on active surveillance 5, 6, 7, 8, 9, 10 years in the future. And we'll have to update this. This is already from, I think, 2022. So, we'll be able to update this in a few more years as well. There is some hesitation, of course. This comes from Toronto, from men that were on active surveillance with grade group 1 and grade group 2 and grade group 3 disease. All right. Showing here that unfortunately, some men with grade group 2 prostate cancer, this is this group right here, 3+4, will, unfortunately, if you get far enough out, develop metastasis from their disease. And this is around a 15% risk here in blue at 15 years. If people compare this and they say, well, 15% risk of metastasis at 15 years if you have 3+4 disease, but a 6% risk of metastasis at 15 years if you have grade group 1 disease, 3+3, well, that's a 10% difference. That's not good. And I agree that that's not good, but I think the comparison there is not fair. When a patient's diagnosed with prostate cancer, they don't get to pick, do you want to be someone with grade group 1 disease or someone with grade group 2 disease? That's not a decision you make. The disease is the disease. The more relevant comparison is, do you want to have active surveillance or do you want to have treatments? And then the question is, are you potentially compromising your cancer outcomes by trying active surveillance? And that's not what we're looking at here. And so I've always kind of pushed back at this data and instead said the more relevant comparison is to tell me, what do your cancer outcomes look like if you have immediate treatment for your grade group 2 prostate cancer, your favorable intermediate risk prostate cancer, or if you need to have treatment in the future. And this is the risk of recurrence, called biochemical recurrence. It's the earliest form of recurrence after you've had treatment for your prostate cancer. It's where the PSA number is higher than it should be, suggestive that there's cancer somewhere. You haven't developed a spread of a cancer yet, but nonetheless, it's our first form of recurrence. This shows if you have favorable intermediate risk prostate cancer, and whether you treat that person up front in blue, or you try active surveillance and then need to have treatment in the future, the risk of recurrence, biochemical recurrence, appears to be similar. And I think that's the much more relevant comparison than comparing the outcomes of people with grade group 1 disease on active surveillance versus grade group 2 disease on active surveillance. That's just not a helpful comparison. So there's lots of questions that still need to be answered when we're considering active surveillance with favorable intermediate risk prostate cancer. I think it's pretty easy when we're thinking about grade group 1 prostate cancer with a high PSA. Well, again, grade group 1 prostate cancer is a disease we're trying not to call cancer anymore. It's more so about the nuance here is going to be about grade group 2 prostate cancer. How much is too much? And that's a question we really don't know. It's kind of expert opinion right now. We just kind of think, we look at patients that have had treatment and try to figure out where those inflection points are. But in terms of actually active surveillance, we really don't know how much is too much. And that's both in terms of the percent of cores that are positive, the number of cores positive, the length of cancer within that core, the percent pattern 4, 5% versus 20% versus 40%. And then thinking about how does that mean in terms of total volume of pattern 4, and then when we think about the number of cores, the length, the percent, is it a little bit or a lot? And unfortunately, we just don't have good guidance here. When do we treat someone? Again, where's that inflection point that where we watch, and if we continue watching, we're truly going to compromise someone's ability to have a good outcome because we've continued to delay treatment? We don't know when that is, truth be told, and it's probably later than what we think it is. Again, we are concerned. We don't want to have someone develop metastasis because we waited too long, but nonetheless, there's still a little bit of lack of evidence here. And I think this is an area that I have been focusing on. All of these questions, for what it's worth, are things that we're trying to focus on, me and my group within music as well. And then lastly, how do we watch? We were talking about this earlier, and I'm sure if we were to talk about this more as a group, how you do active surveillance is very different. And truth be told, it's not very data driven. It's just kind of like, well, yeah, things appear to be pretty stable right now. Let's just get a PSA in 6 months because in my mind, your risk of upgrading in the next 6 months is very low, but it's not a very data driven process. And, how often should we be doing things like PSAs and MRIs and biopsies? You know, that is probably more of a real-time risk assessment that's not so much a prescribed algorithm that unfortunately we are not doing a very good job of doing this in a very data-driven process. But I think with the machine learning technology that we have coming on board, hopefully we'll be able to synthesize in real time someone's previous history up to the present to determine in a more data-driven process what the next step should be and not just kind of a little bit of, you know, prescribed, well, PSA every 6 months. So, in conclusion, active surveillance is very safe, especially when done appropriately. I'm going to say that this is the standard of care for all men with very low risk and low risk prostate cancer. And I think active surveillance is underutilized, and it really should be an option for not select men with favorable intermediate risk prostate cancer, but I would say many men with favorable intermediate risk prostate cancer probably could be eligible for active surveillance with very little chances of compromising cancer control. And these are my two tiny humans holding rocks from Part in Michigan. This is a Petoskey stone for people that can see. These were gifts of mine from a patient. I just thought it was a cute picture that I put it in. Actually, not a prostate cancer patient. She had bladder cancer, but nonetheless, thank you very much for your attention and your time and giving me a soapbox to preach from.
Well, Kevin, pardon me, need a drink. Thanks for your presentation. We're going to go in for question and answer. We'll be switching between me, Jeff McLennan, and David Keller. I'm going to start off with a couple of questions. I was on a panel. I was the first patient ever to appear at a meeting of the American Society of Clinical Oncology. There's a whole other story about how they almost forgot me on the stage, and I ended up giving a 7-minute rant on what was wrong with that picture. But sitting next to me was Dr. Hamdy, who ran the PROTECT trial that you described earlier. And PROTECT is really an important trial that found that surveillance was just as safe as aggressive treatment. But one of the things he told me after the meeting, and this was in 2016, was he felt that the future of active surveillance was going to be Gleason, the favorable Gleason score of 3+4. He felt that eventually low risk prostate cancer was going to be more or less phased out for surveillance at some distant point in the future. But I know that's happening in England. The percentage of Gleason 6 on active surveillance is shrinking because of MRI and their reliance on MRI. You know, they're just not diagnosing as many people with Gleason 6. So I wonder what you think. Is this happening in the US? Is there a shrinkage of Gleason 6 on active surveillance?
Well, I think we are certainly diagnosing fewer grade group 1 Gleason 6 prostate cancers. We have some data that we're going to show at the AUA this year, where it's basically just 10 years of prostate cancer care in music, showing that the use of pre-biopsy MRI, has increased over that time. And correspondingly, we've seen a big decrease in the amount of grade group 1 prostate cancers that we're diagnosing as a proportion of all prostate cancers. For the point that you're making is that we're just not looking for them as much. We're not trying to find them. That being said, I think there's still a lot of prevalent cases of men who have grade group 1 prostate cancer that are going to be on active surveillance for the rest of your life, like many people here are diagnosed 10 years ago. And so as a consequence of that, we're having fewer incident cases of men with grade group 1 prostate cancer on active surveillance, but we still have a lot of prevalent cases, thankfully, which is a good thing, of men that are just going to continue on active surveillance for the remainder of their lives.
what do you mean by prevalent? And I didn't catch, I don't remember the other word, prevalent versus
Yeah.
what?
Good point. So incident cases are new cases, cases being diagnosed today. Prevalent cases are cases that were diagnosed a long time ago that are still in the pool. All right. So we are like probably what Dr. Hamby said is we're diagnosing less grade group 1 prostate cancer. So we're putting fewer men with grade group 1 prostate cancer on active surveillance, diagnosing more low volume grade group 2 disease. More of those men are going on active surveillance, but there's still all the men that were diagnosed 10, 15, 5 years ago with grade group 1 disease that are still on active surveillance that it's going to be some time before that really flips.
Um, I'll ask one more question, then I'll pass it over to David. Okay, the Cancer Society estimates that this year there will be 300,000 newly diagnosed cases of prostate cancer. Can you tell us what proportion of those are low risk? What proportion of those are 3+4 or grade group 2? And what proportion are grade group 3? What's the breakdown?
Sure. So again, we're going to present some great data at the AUA this year about how over time the biopsy grade groups really have shifted. So, for example, we are now just looking at our data in music. Around 20% of prostate cancers diagnosed in 2024 are grade group 1s. Around 25% are grade group 2 disease. And then we are still seeing some, I'm sorry, this is all prostate biopsy. I'm sorry, this also includes negative biopsies as well. So 30% are negative. But we are certainly doing a better job of trying to diagnose fewer grade group 1 diseases. That's probably less than, 10, 20% now of most prostate cancer diagnoses.
Let me clarify that. You mentioned 20%, you mentioned 30%. So which is which?
So around 30% of prostate biopsies in our collaborative are grade group 2 disease, have grade group 2 disease on the biopsy. And it's around 20% are grade group 1.
So like 5 years ago, what would it have been?
Probably fairly similar. I don't know if I have that exact number in front of me, but I would bet you it'd be probably a little bit more grade group 1, a little bit less grade group 2. Again, probably because more biopsies being performed just for elevated PSA without the use of MRI or other biomarkers to really determine is that a risk of a grade group 1 disease there that now we care less about, or is it a grade group 2, 3, 4, 5?
And do you reckon, I saw a lot of negative comments about biopsies and, from those of us who've undergone biopsies. But do you recommend a pre-biopsy MRI?
I do. As long as it's not a financial hardship for someone, I've found that insurance companies will pay for MRIs, thankfully. And I think that there's ways that we can make the MRI even smarter. Someone said earlier it's not as sharp of an instrument as we like to think it is. It's true. There are limitations to it, but I think it's very helpful if we can do things like layer in PSA density in particular to tell us to help make that MRI even smarter. So if I think someone needs a biopsy in my practice, I want it to be the best biopsy possible. And so an MRI
Well,
before
I
that.
may as well drop the other shoe. Do you prefer transperineal over transrectal?
So I do both. I do transperineal and transrectal. I know transrectal is a ugly word. That being said, there's now there's high quality evidence, two randomized trials now, each with about 700 patients in them, that shown that the risk of infection between transrectal and transperineal is very, very similar, and both are very, very low, less than 1% in each in the ProBase study I don't remember which is whose now. In Jim Who's study, there were no sepsis events in either arm. There was also then Mian's study that also was very similar. What is higher though, and is pain. That by visual analog scale, the kind of just 1 to 10 pain levels, 8% of patients, or sorry, 1 in 8 or 13% of patients said that their pain during a transperineal prostate biopsy was higher than a 7, which is considered significant pain. And that's 1 in 8 people. So I'm a little bit more selective about doing transperineal now, given that the evidence really would suggest that they're both very safe. And so I do both, but I do tell patients that unfortunately, there is some downside to the transperineal, which is it can be more painful.
And David, why don't you dive in?
Okay, can you hear me okay, Doctor?
Yes.
Okay, great. I've got a few questions, but I have a foundational question that we've been kicking around and we don't have an answer to yet. And that is, can a Gleason 3 cell turn into a Gleason 4? And we have some reports that no, it'll never change, it'll never metastasize. Here's the big umbrella question. Does a nice, healthy Gleason 1 prostate cancer, a prostate cell, migrate through these different stages? I mean, how, or does it just pop out of nowhere? You can get a 3, you can get a 5. They don't move in stages. It's not a general degradation. Please help us understand that.
God, I wish I knew the answer to that. That is hotly debated. That is it when someone has initially grade group 1 prostate cancer and maybe 2, 5, 10 years down the line, they now have a grade group 2, 3, or 4, or 5 prostate cancer. Is that evolution of that, or is that a de novo growth of a new tumor? I tend to believe, and this is my kind of understanding, and there's certainly lines of thought in both directions, that I tend to think it's growth of a new tumor. It's less of a kind of stepwise kind of progression. It's kind of my thought, but the jury is certainly still out on that one.
Okay. Oh, thank you for that. So in your estimation, a tumor appears and it appears at a 4 level. It's a de novo, it's a new tumor, and it just appears at a 4 level of malformation, is my phrase. Is that what you're saying?
That's kind of my bias, but admittedly, I don't think we really have the answer to that one yet.
Okay. I really loved your presentation. I'm going to go back and look at it. So I'm going to ask you a couple of technical questions. When you show a graph that on the vertical on the left, it shows a 1.0, what does that 1.0 mean?
Yeah, I'm sorry. I should have that's here. Let me bring one of those up there, because that was not if that's not clear. So here's
Is that 100% of the time? I mean, I don't know what the
here.
1.
So let me share this again. So when we're looking at something like this is called a Kaplan-Meier curve. Up here, so what we got down here is cancer-specific survival. So up here, everyone is alive and well. 100% survival. All right. And as we decline, and if the line were to do something, I'm going to put the pointer on, so, or maybe
Okay. Okay.
if the line is like this,
Got
okay,
it. All
this is
right.
now when we kind of reach this point, this
Mhm.
is now 60% survival, or
Okay.
40% of people have died from prostate cancer in this case. All right. Or over here, if we were to imagine where the 50% would be, uh-oh. Oh goodness. It didn't like all the
That's
clicks.
okay. Yeah.
This here would be at this time point, 50% of people have now died of prostate cancer. At this time point, this means 80% of people have died of prostate cancer. So when we look at Kaplan-Meier curves that are like this, very high, this is meaning that most of these men are alive and well, have not died of prostate cancer. But if you were to imagine there's probably something right here, maybe around 95%, cancer-specific survival, or a 5% risk of death of prostate cancer. And then
Okay.
this is just the inverse of this. This is now saying cumulative hazard or incidence. And so if this curve were to look like this would mean that at this point, half the people have developed metastasis or death from prostate cancer. At this point, 20% of people have developed death from prostate cancer. And so I'm sorry if that was not clear.
You probably said it and I just didn't pick it up. And
I may have, kind of one of those unfortunate things of where I assumed and made an ass out of you and me. So,
and there's another QI. It's in there a number of times. You probably
quality
mentioned
improvement.
quality improvement. Okay.
Yep.
And EMR. I'm sorry, that's the last
No, it's
acronym.
all good. Electronic medical record.
Okay. Sorry for everybody out there who knew all this. Cribiform. What does cribiform, where does that play in all of this diagnoses?
Yeah, so cribiform is one of the patterns that would fall into that pattern 4 area. It is generally thought to be more aggressive type of cancer. And admittedly, what that means in terms of active surveillance
Yeah.
is a little uncertain. It makes us a little concerned, but like anything, I don't think it drives the risk of death from prostate cancer of 2% to 100%. It's still prostate cancer, but I think the risk is a little bit higher. And so personally, when I see patients that have cribiform histology, I don't necessarily, I don't want to talk in absolutes. And so it's not like I say you must have treatment, but I would say that the risk is higher. We should consider that when we're making our decision in terms of to either continue on active surveillance or to start on active surveillance. Potentially, it's a little bit higher of a risk, so we're going to watch a little bit more closely. But it is a adverse feature, and exactly how we handle it in terms of active surveillance, as we're still learning more about active surveillance in the men with grade group 2 disease population, is unknown.
So cribiform, I guess that's some sort of a malformation or something that appears under your microscope.
It's just kind of the pattern of how the cells are.
Okay. And it only appears in the 4 area. Am I hearing that right?
Yes. I shouldn't say yes so confidently, but I believe it's only 4. I don't think you can have cribiforming pattern 5.
And if there's a lot of it, or if it's a really ugly formation of it, that's more risky than a different form of it, or is it always terrible?
So pattern 4 itself has a couple different types of criteria to get you into that pattern 4. Cribiform is one of them. And so those cribiforming glands are within that pattern 4 group, kind of
Okay.
we think of it to be a more aggressive type of pattern 4.
So if we get a pattern, and I'm sorry, everybody out there, I hope I'm not driving you crazy with this, but a lot of us have a 4 in our pathology. Should we be asking the pathologist to tell us if there is or is not cribiform in the 4?
A lot of the pathologists should report that, but if it's not listed, so it's always one of those things, is the absence of evidence, the evidence of absence. So if it doesn't say cribiforming, does that mean it's not there? So our pathologist kind of has like a checklist that they'll specifically comment, no cribiforming glands noted.
Okay.
Isn't there, if I can interject on this too?
No, go ahead. I'm done.
Yeah, well, on the same topic, isn't there a distinction between sort of a large cribiform and a small cribiform?
Do you mean volume of cribiform or like a subtype
No,
of
I don't know how it's defined, actually. There's just a guy I know up at University of Toronto, a patient, and he basically was told that he had a smaller version of cribiform, or, I don't remember the exact terminology, and was told that it was no big deal, as opposed to a large variety of cribiform. Could be volume, I don't know.
Well, I'm not certain, Howard. I'm sorry. I'm going to have to take a pass on this one.
Yeah, it's fine. Hey, Jeff.
Hi, good
Jeff,
morning.
I know you got to leave soon, so why don't
Yeah,
you?
thank you, everybody. I'm still here in the West Coast. So as far as I know, the Pacific Ocean is still west of California. Doctor, thank you very much. What is the cutting edge for a 3+4, what I call FIR, active surveillance? And let me also add, in this so-called cutting edge, do we determine age? And I haven't heard much about family history or genetic testing.
Sure. So start with the ones that the family history. Um, is I in my personal experience, I think family history is more what kind of gets you to the point of a biopsy and a diagnosis. But at that point in time, once you have your cancer, or you don't have cancer, it's more about what's in your prostate. It's more about your PSA density. It's more about your specific factors and less about family history. Um, the other part of that you said about genetic factors is certainly a point of ongoing debate as well. And just to be clear, difference between genomic, which is kind of like the things like Decipher and Prolaris and those sorts of things, and truly genetic, and that's more like your germline, like what you have inherited from your parents. And some of those mutations, things that are very common to the medical community and patients, like the BRCA1 and 2 genes with breast cancer, actually can be associated with prostate cancers as well, as well as some other genes in there as well. And so
Thank
those, again, I would say increase some risk, but again, nothing is really absolute, 100 or nothing. And so I think there's some concern that patients that do have those mutations are at increased risk of more aggressive prostate cancers, probably should be watched more closely, but not necessarily need to be excluded from active surveillance. At least that would be my recommendation for someone
you.
who does have, a pathologic variant for, let's say, BRCA1 or BRCA2 or ATM, something like this.
So you could still have them on a favorable and immediate 3+4 program is what I was getting at.
Yes.
Thank you, doctor. One more quick question. Is PSAD reliable? I'm one of these older guys. I guess I'm getting towards the plum of the grapefruit size prostate. And I'm just asking myself, how much does this BPH crowd out real accuracy with PSAD and on down the line?
Yeah, I mean, I personally am a big believer in PSA density. I think what that does is it smooths out a lot of that variation that sometimes we can see. For example, it's not uncommon to have a PSA jump up a point and then drop a point, and that can be very concerning to some folks when you just look at the absolute value. But when you consider how that changes the PSA density, increasing a point and decreasing a point, when you have someone who has a 40-gram prostate, you're going to minimally deflect the PSA density. And so, in terms of thinking about, yes, sure, the absolute rise in PSA may have changed a gram, but our PSA density went from 0.08 to 0.1 or something along those lines. Well, I'm like, well, that's still a pretty good PSA density. So I'm a big believer in PSA density. I like to trend that over time while on active surveillance, not just the PSA. I kind of have tables and I put them side by side so I can see kind of over time how everything is changing. But I think PSA density is a nice way to kind of smooth out some of that fluctuations that we sometimes can see with PSA that can cause a lot of anxiety.
And finally, doctor, PSA free. Some years ago, they stopped taking it on me, and I started to question it and did a little research. And now I'm wondering, for certain tests and certain procedures at certain clinics, should they still be taking PSA free for us older guys?
So the original percent free PSA, the use of it and the numbers that are often reported, if you look at a lab slip, it will say various cutoffs for percent free PSA. That was for men with a PSA between 4 and 10. And then it tells you the risk of any prostate cancer, which is probably less helpful when you're on active surveillance and you already know that you have prostate cancer. Um, it would be nice if we could retune those, if PSA percent free PSA could be worked in a way where it can tell us instead the risk of a clinically significant prostate cancer. So if you've got grade group 1 disease and you're worried about having grade group 2, 3, 4, 5 disease, et cetera, it'd be nice if those percent-free PSA thresholds could be validated for that outcome instead of just any prostate cancer, because certainly if you already are on active surveillance, some prostate cancer already exists there.
Okay, and then a question from Celine. This will be my last question, gents. Celine is asking how high a PSA, 50, 60? Are we talking about a balloon that keeps going, or how does this work?
Yeah. I tell patients all the time, PSA is the least important part of this puzzle. We have the biopsy is truthfully at this point in time is the most important piece is king. MRI is kind of queen, and then PSA is kind of like the court gesture. It's there. It's something that we check. But truth be told, I have patients who have PSAs where they just have a lot of PSA in them. They've got prostatitis, whatever it may be. Their PSA is routinely 30, 40, jumps around. But we've done biopsies and we've determined that they have low volume, grade group 1 prostate cancer. It's just something about them makes a lot of PSA. As far as I'm aware, and as far as I know, no one dies of metastatic PSA. They die of metastatic prostate cancer. And the disease that's in the prostate is not very, very aggressive, or in some cases, just straight up unaggressive. Well, I'm not going to say that someone should have treatment for their prostate cancer just because the PSA is high, especially when we know what's in the prostate is not harmful to them.
All righty. Thank you, doctor.
Well, we probably just have 12 more minutes and we have a ton more questions. And Kevin, you still have to pick up your family at the airport, so we can't ask you to stay later.
But I'm happy to answer. I'm going to go below my desk for a second to get my power cord because my computer is going to die. But I'm happy to continue to ask questions or answer questions.
Okay. There's a little bit of a debate going on here. In essence, whether the urologists are getting rich off of prostatectomies. And I hate to put you on the spot on that, but what I'll share what I have found, and tell me if I'm wrong. I mean, if a urologist wants to make really good money, he or she should do a lot of biopsies, because that's the best way to make the most money in the least time. Active surveillance is actually a good way to make money for the urologist, because at a certain point, like 3 years into this, the urologist starts making more money than if he had done a prostatectomy. And, it could be the gift that keeps on giving. So what is your take, if you're able to talk?
Well, I get paid pretty poorly regardless of what I do. But I think that there are I don't think the overtreatment of prostate cancer was driven by financial incentives. I think it was driven more so just by the lack of inertia. So at the time, just prostate cancer was treated, and there was probably just legitimate concerns that there was going to be harm by not treating, and it took time and to reverse that kind of mindset and to get to a point where people were very comfortable with active surveillance. That being said, I think that, again, there's many better ways to generate revenue in prostate in urology and in prostate cancer than by doing prostatectomies. And so hopefully, though, that is good in the regards of that will hopefully decrease the amount of overtreatment, because really there's not a lot of financial incentive to take someone to the operating room to do a prostatectomy in terms of spending their time other ways. There's better ways to generate revenue.
There are a couple of guys that present different sides of the coin with their experience. Some were told that they had cribiform and they got a second opinion and were told they didn't have it. Or the other way around when they got a second opinion. How accurate are these biopsies? And how accurate are MRIs?
Yeah, I mean, this is a big problem, but it's also not a big problem. And it's hard, right? Because, we're saying that there's, the way someone reads an MRI can change whether or not what management is being done. The way someone reads uh, I'm not sure if I started with MRI biopsy, but the way an MRI is being read is determine whether or not we're having a biopsy in the first place. The way the biopsy is read is going to help with various management strategies and what is best for the patient. Yet, despite the fact that there's all that variation and people who don't get second opinions, people who just stick with one opinion, for example, let's say someone was initially diagnosed with grade group 1 prostate cancer and then gets reread by someone and now they say, oh no, this is actually grade group 2 prostate cancer or grade group 3 prostate cancer and you should go have treatment. But that first patient never got that second opinion, so they just think they have grade group 1. They start on active surveillance and they do very well for a period of time until they have a repeat biopsy and now someone reads that biopsy and says, hey, you got grade group 3 disease, and then they go on to get treated. And so even though there are those differences in there, the patients still do really, really good. So, I'm a little bit of of a at first do no harm kind of person. And so I would, just be a little cautious of some of those things where it can muddy the water by having, a lot of conflicting opinions to it. I'm hopeful that we're going to have the use of AI in the future can help circumvent a lot of these issues, and can kind of help standardize a lot of that variation, that can cause, again, a lot of distress now that you've got who's right and who's wrong. I've got two different pathology reports in front of me. Which one do I trust?
But Kevin, just bottom line, how, in a percent, based on a percentage, is it 20% inaccurate? Even the best pathologist gets it wrong 20% of the time. Do you know those numbers?
I don't have an exact number, but I bet you 20% is pretty close. I've seen some studies where, they've got expert pathologists that look at slides and the inter-rater agreement and disagreement between them. I think it's in that 20-ish% range.
And same with MRIs. Is it also 20%?
That one I don't know. I I'm not sure about that one, other than, again, it's a very, MRI is a skill. Reading MRIs is a skill like anything else, and it unfortunately varies depending on degree of expertise.
By the way, one of the attendees, Joe Mangrone, sent along a link to a study talking about large cribriform glands versus small ones.
Oh.
So it's a thing, Kevin. It's a, David, do you want to weigh in again? David, we're not hearing you, David.
A couple of other questions. These are very broad-based, so step in for more specific. One is when we talk to prostate patients and they're getting opinions from different urologists, one of the things that I'm starting to tell them is that, let me ask you, Kevin, is it fair to ask a urologist what percentage of your practice actually deals with the prostate? How many subspecialties are there within the urology world? I understand it's about a dozen. And so is it fair to ask your urologist, do you just spend a lot of your time on bladders and, women reproductive areas, or do you spend 90% of your time? We're trying to discern who to pick to turn our life over to.
Well, David, that seems like a slam dunk, if I can say so, Kevin. But, along the same lines, I think it's fair play to ask, how many prostatectomies do you do in the year? What percentage of your patients are on active surveillance? I mean, isn't it? It's all fair in love and war, isn't it?
I wouldn't have any issues if someone asked me those questions. There's around half a dozen subspecialties within urology. There's female pelvic, there's infertility, there's robotics, endourology, there's oncology. So there's around six or so in adult urology, and there's pediatric urology. But I wouldn't be offended if anyone asked those questions. I think that's fair. But I would say, though, that some of this can lead to very real access issues. And that is, I'm very lucky. I work at a, NCI designated comprehensive cancer center, and I'm a urologic oncologist. But I'm also just busy and just trying to help as many people as I can. And, we need the boots on the ground people. We need general urologists that are in the community, that if there's one urology group that's servicing a 50-mile radius in a rural part of a state somewhere, it's not practical to think that, only the care can be delivered at, the ivory towers of urology. And so I think some of it is that in general, even general urology is a very cancer heavy specialty where there's a lot of cancer training in residency. And I think that the probably bigger questions that we should be asking is less about volume. It's probably just more about, are we meeting just kind of the standards, and is the care meeting what we would say is just like an acceptable standard of care? And those things I think you can get to by asking about practice patterns, about, how do you manage low risk prostate cancer, even if they only, in a busy practice where again they're providing to their 50-mile radius, they're doing incontinence, they're treating the kidney stones, they're treating the BPH, they're doing all this stuff, but it doesn't mean that they're doing prostate cancer necessarily wrong, because they could be doing everything right. Maybe they are putting, 80-90% of their guys on with low risk disease on active surveillance.
Thank you. That's a good answer. I really appreciate that. I had in your studies, somebody's going to slap my hand for bringing that. Maybe offline, we'd like to ask you about BPH. There's a lot of us trying to figure out how to address it, but I don't want to get off track. But we're certainly looking for the right, I guess, the miracle cure to get that flow back. And chemistry. Have you heard of anything, back to prostate cancer tumors? Have you heard of anything that will reduce the size of a lesion other than radiation in your prostate? I mean, is there any? Yeah.
So Stacy Loeb, I think, recently published some data on a plant-based diet in terms of men on active surveillance that follow more of a plant-based diet tend to have less risk of biopsy upgrading in the future. Additionally, when we think about just the natural history of prostate cancer, that it is generally a slow growing type of cancer that takes 10, 15, 20 years to be harmful. When we look at PROTECT, most men in PROTECT, with or without prostate cancer treatment, died of heart disease than they did of prostate cancer. And so I tell my patients, do as I say, not as I do. Follow more of a plant-based diet and a heart-healthy diet, because ultimately you're more likely to die of heart disease than you are of prostate cancer, depending on the, certain variables. And so I just tell folks that, make sure you're taking care of your health, taking care of your heart. And then again, I think the best evidence in terms of not necessarily shrinking the prostate cancer, but maybe in terms of just decreasing the risk of needing to have treatment in the future is by following a plant-based diet.
Okay.
And I'm going to take it now. Kevin, you brought this up briefly during your talk about whether grade group 1 should be renamed as non-cancer. It's a pretty hot topic. I think the research shows that 50% of urologists support the idea. Only 5% of pathologists do. We did a study through this group and other groups of 460 men, and we address things like, would you quit surveillance if they stop calling it a cancer? Only 5% said that they would. And 82% said they would stay on surveillance. But my question is just to you personally, do you support the name change, or do you think it's better to leave things as they are?
So I support the name change wholeheartedly. I know pathologists don't like it because they say when they look under the microscope, it meets the definitions and criteria needed to diagnose a cancer. So they say it's a cancer. Um, but when you tell cancer to a patient, all they hear is cancer. And it's very hard, despite the fact that I try and walk it back all the time about how this is very different from other types of prostate, other cancers, very different from even other types of prostate cancer. It doesn't behave in that way. It doesn't spread to your lymph nodes and your bones and be harmful to you. It doesn't cloak. It doesn't, as we would think, act in the way that a cancer should. And it doesn't do the things that a cancer does when we hear the word cancer. And so for that reason, I'm very pro changing the name. I don't know what the right name is. I don't like the argument as well. People will take it less seriously if we don't call it cancer. They won't follow up. But if you think about, there's many corollaries to this in breast cancer. There's corollaries with this with colon cancer that you can have a perfectly pristine colonoscopy, like a negative biopsy, and you get shunted into the lowest next steps for follow-up. You can also have a colon cancer, like a prostate cancer that needs to be treated right away. But there's also some of those colon findings that are not true cancers, various adenomas and polyps that are concerning enough that you're not in the completely low risk category, but you're also not in the category that needs immediate surgery or treatment. I don't know how colon cancer is treated, but whatever they do for colon cancer, that grade group 1 prostate cancer could fall into that too. That you say, like, listen, this is, whatever we're going to call it, something prostatic neoplasm. It is, something that can be associated with having a more aggressive prostate cancer in the future. So we're going to watch you a little bit more closely. But I think that would be public health wise, would have huge implications in reducing overtreatment of grade group 1 prostate cancer.
Great. Now, Jay Levine asks, is vitamin D helpful in low-grade Gleason 6 cases?
I don't know. I think there's a lot of data about vitamin D in health in general, and I think that's very encouraging and just staying healthy. But I'm not certain I've seen anything, and that's not to say it doesn't exist, in terms of vitamin D levels and vitamin D supplementation in terms of reducing the risk of upgrading or treatment in the future.
Howard, we need to let Kevin go. He's got to get to the airport to pick up his wife and kids.
So many good questions. Why don't we ask him if he wants to stay or if he's really got.
I got to be out. I could give you 5 more, but I do actually have to leave by around 1:45. So if I could maybe
Okay.
do a couple more minutes, and then I've got to myself use the restroom and then get out the door.
All right, I'm going to ask a few from chat. At what point does it become advisable to leave active surveillance and be treated somehow?
Yeah, so I mean that is the $1 million question. Where is that inflection point where if we continue to watch, we're going to truly risk our ability to have a good outcome in the future? And I don't think anyone knows where that is. We can say, very extreme examples of that. Of course, if you find some pattern 5, some grade group 5, some grade group 4, even that though, like it is again some shades of gray there because that one core of a grade group 4, maybe 5% of it, the needle hit just that pattern 4 in such a way that you have 4 plus 4 only, but just tangential to that is all this 3 plus 3, and really the sum of that patient's prostate is going to be 3 plus 4, that grade group 2, and so it's a little bit of a moving target in terms of how much disease is too much disease to watch. When are we truly going to impair outcomes? and we need to switch to treatment. It's tough. That's a tough one.
Dr. Ginsburg, you represent music so well, and we are so pleased to have given the award to music. The leadership of music in Michigan in this area has been outstanding, and thank you so much for dedicating this time to us today. Much appreciated.
My
If I
pleasure.
wanted to sneak one more in, the PDI, if you've got a PDI below 0.15, can you postpone a biopsy?
So prostate density, we mean
Yes.
PDI? I think it depends. That's one factor. So in particular, I think if you have a MRI that shows PIRADS 2 and a low PSA density like that, like there's a lot of people have shown that if you layer those in together, the risk of having a clinically significant prostate cancer in that scenario is probably less than around 5%. And so in general, that is kind of my practice, that if patients, the PSAs, been 3 or 4 years floating around, four, a little bit above, not a huge steep rise, and their biopsy is negative, and their PSA density is around 0.1, less than 0.15. I tell them that I feel very comfortable avoiding a near-term biopsy in a situation like that. Maybe a little bit different if the PSA went 1, 2, 4, 6, something like that over the last 3 years, and the PSA density is also in that similar range. Well, that's someone I'm concerned the next time I check their PSA, it's going to be 10. And so that's someone who might get a biopsy, even if their PSA density is favorable in a situation like that.
Thank you very much. I'm complete.
Thanks. And
Thank you so much for making the poor decision to invite me today. This was great. Howard, as always, please stay in touch. And
Okay.
I look forward to the next opportunity to talk with the group.